Hi everyone, Jessie here today. Me and Brooks, the team IBS Dietitian, are going to talk about SIBO, small intestine bacteria overgrowth. And it has some overlapping symptoms with IBS, and also IBS is an overlapping condition with SIBO as well. So we'll talk about, what are the different symptoms of SIBO compared to IBS, what you can do to stop SIBO from coming back, because SIBO is oftentimes one of those conditions that you get it treated, it recurs, and then you get it treated again, and recurrence can happen again. When we see that a lot in our clinic, we'll also share with you some of our success stories on helping patients treat their SIBO as well. Now, Brooke is joining me, so we'll come. Thank you so much for joining. Can you all hear and see me okay? We are always a little bit tech challenged here. Okay.
Hello.
And for those of you who are joining us, tell us where you are joining us from. And Brooke, do you want to say something about SIBO, how it might be different, or how many types of SIBO are there?
Yeah, so SIBO, there are, three types of SIBO, kind of. There's hydrogen dominant, there is methane, which is actually called intestinal methanogen overgrowth. It's actually archaea. And then there is mixed, you can have both hydrogen and methane overgrowth.
Yeah, and if you guys have any questions, you can put them in comments. We'll go through them shortly. But we kind of want to talk about, different types of SIBO symptoms, how it is different than IBS. Do you want to maybe start with that as I'm typing here? We'll get to Q&A
Sure.
shortly.
So SIBO symptoms will often include more upper GI, so kind of above your belly button bloating, and burping after eating. And these symptoms usually happen within a few hours after eating. And you can also get bloating after eating anything, or sometimes even drinking water. You can get that bloating. Um, and a low FODMAP diet will not be as effective for SIBO as it will be for IBS. Although it can be helpful. So that's kind of a person
Mm-hmm.
to person. Actually,
Yeah.
everything's person to person, but yeah, depends on the person.
Right. Oftentimes it's helpful with symptoms, right? But
Hmm.
it doesn't cure SIBO. Like some people would say, if somebody says, your diet can cure SIBO, you got to be very careful with
Hmm.
that. And
For
let's,
sure.
let me go back a little bit to SIBO symptoms too. SIBO symptoms can be upper GI. A lot of the times that's what we see. People get bloated very quickly after a meal. Usually is within 30 minutes to maybe 4 hours, and then that bloating goes away. But every time you eat, the bloating comes back. I think that is the biggest difference between SIBO and IBS. Now, however, even within IBS, there are different types of bloating. Some people without SIBO can still have upper GI bloating as well. So it may or may not necessarily be SIBO. It's one of the symptoms. I think we had a post
Hmm.
yesterday that talks about, what are some of the overlapping symptoms with SIBO, and what are some overlapping symptoms with SIBO? Let
You,
me pull up that post because I really like that charts that we have. Let me see. Hold on. I think the biggest one, right, the overlapping one is bloating. But depending on where your bloating is, it could be an indication of, if it's a lower abdominal bloating that happens later on in the day, those are more usually associated with chronic constipation or stool burden building up through the day. If it's more middle, sometimes if it's in the middle, it could be IBS, it could be SIBO, because different types of SIBO, again, bloats differently as well. If it's more hydrogen or more upper GI in the small intestine area, it tends to bloat upper above the belly button or in the middle of the abdominal area. But like what Brooke was saying, if it's a different type like IMO, intestinal methanogen overgrowth, which is one type of SIBO, that can be more lower GI as well. So different types of SIBO also have different types of bloating. An experienced provider will be able to assess your bloating, your pain, to tell you, what it may be, whether to test for it. Test can be helpful to get an assessment for baseline, but it's not always necessary. And it's not as accurate as we want it to be. I think that is a drawback when it comes to, using breath test as a testing method for SIBO, but it's really the only tool we have. And it just has a high false positive and false negative rate. It's at about 47%. So, it's good to, have an overview to see, could it be a possibility, but it may not give you the full picture. But so let's talk more about symptoms. So when it comes to SIBO, people don't bloat consistently, right? Like we said earlier, when people eat, they get bloating for a few hours following eating. And that bloating or belching, that also happens at about the same time. So when there's like substrates in your small intestine that gets fermented, and then, you produce more air, you get more gas in the middle that causes the bloating or belching. And that tends to go away after a few hours. But when you start eating again, it will come back. It can come back. Whereas with IBS, the bloating doesn't quite go away. But again, depends on what type of IBS you have, what other symptoms you also have. There are so many different reasons why somebody bloats with IBS. If it's IBS-C, it could be related to backup. If it's, consuming FODMAPs, that could be, causing bloating as well. And then also what we see is non-celiac wheat sensitivity that can cause bloating as well. And sometimes, some of these cause more upper GI symptoms. For example, like osmotic FODMAPs, because it starts drawing fluids in a small intestine. And that symptoms can be very similar to SIBO symptoms, right? But then you also need to look at, whether you're burping or not and how often that happens. I think that's something we usually, have our patients track, right? How bad is your belching? From 0 to 10, 10 being the worst, you're belching out a whole sentence, or you're singing a song, you're belching out a song, then that is really bad. Then that's usually a red flag for us saying, okay, definitely have SIBO. Do we want to test it, or do we want to talk to the GI about trialing a round of antibiotics and see how things go? So that's SIBO symptoms. Other symptoms that SIBO and IBS both have is pain, sometimes diarrhea, sometimes constipation, nausea, fatigue, loss of appetite, and gas. We kind of already talked about that. Did I miss anything?
I don't think so.
Yeah. So it's a lot of overlapping symptoms. And a lot of the times, not a lot of the times people with SIBO will also have either IBS, celiac disease, inflammatory bowel disease. So it's very common to have both conditions. And with SIBO, the key is really not just treating it, but understanding why it comes back. Okay, maybe we should move on to risk factors of developing SIBO, right? These are really key, right? For everybody to know, what your risk factor is. If you don't know what makes you at higher risk of having SIBO, then you don't know how to prevent it from coming back after getting antibiotic treatments.
Mm-hmm.
Yeah.
So anything that is going to change your motility, so either speed up your motility, or decrease your motility, like something with constipation. So like Jesse said, celiac, undiagnosed celiac disease, non-celiac gluten sensitivity, these can all change your motility. There is also a history of prolonged antibiotic use or long course of really strong antibiotics is going to obviously kill a lot of your which can then change the balance of things, which could lead to an overgrowth of microbes. So taking PPIs for usually long term, or through to the GI tract, which is gonna, stop things up for a few days because you're gonna want to do some bowel rest afterwards. Um, and what we end up seeing a lot in practice is probiotics, the use of
Yeah.
probiotics, long-term use of probiotics for
Hmm.
just, and a lot of people take those just because they think they're supposed to because they're healthy.
Yeah. So for those of you listening, probiotic use is not recommended for IBS as far as literature goes, because in the US, our regulations for supplements is very weak. You really don't know what you're taking when you're taking a probiotics. And third-party testing for probiotics is very, very rare. And one of the things we see for people developing SIBO and persistent SIBO is really taking the wrong strains of probiotics for a long time. And sometimes, people even get, most of the time what we see is a lot of bloating and belching and diarrhea. And then once, we get it treated, stop the root cause, which is taking the probiotics, it can go away pretty quickly. However, sometimes because, sometimes a recurrence can still happen. And this is especially true for methanogen overgrowth, and that is the constipation type of SIBO, or the SIBO type that is usually related to constipation. Then in those cases, we need to dive a little bit deeper to see what is going on, what is causing the motility change, and what we can do to help improve the motility and stop the SIBO from coming back. And I think another risk factor that we want to talk about is people who have had past gut surgery, which is something we see too sometimes, that put them at higher risk of having SIBO. But usually with those gut surgeries or pancreatic insufficiency or even diverticulosis, we see other things impacting it as well. For example, if you've had gut surgery or diverticulosis and then you take probiotics, your risk of having SIBO will be greater than people with a normal gut having SIBO. So, and again, too, we really don't recommend taking any probiotics long-term. Probiotics does not help restore your gut microbiome. It does not help improve your gut microbiome. It can help in managing specific symptoms, right? But you do have to match the right symptoms with the right strain. Otherwise, you're putting yourself at risk of developing SIBO and having SIBO recurrence, which is sometimes, it's really sad. One of our past clients, this is a he, okay, young man, loves, fitness, loves taking care of himself, no gut disorder at all whatsoever, perfect, clean slate of health, clean family history, no family history of gut disorders. But one thing he loves doing is going to the supplement stores and buy supplements to help make himself stronger. And one of the things that he was recommended by the store people was probiotics. And of course, on the probiotics, you go to the store shelf, you can see, they make all sorts of claims. They can help you reduce belly fat. They can help you reduce bloating. They can help resolve your constipation. And what people don't realize is oftentimes when you start taking it longer and longer, you start developing diarrhea. And that's usually signs that your gut microbiome is shifting, maybe potentially because of the use of the probiotics. And that can give you SIBO. And that's exactly what happened to this young man. And poor him, he was only in his 20s when this happened, and he had been dealing with he then started developing IBS mixed bowel type symptoms. So he would go back and forth between constipation and diarrhea, and he would have really loose stools multiple times a day. And then he got a diagnosis of SIBO. And even after 2 rounds of antibiotics, it didn't resolve his SIBO. So, when you take probiotics, it can, put you at risk of developing SIBO that won't go away. And what we ended up doing, and that really helped him, was improving his gut motility, because he was going back between constipation and diarrhea. And again, slower gut motility is another risk factor for SIBO recurrence to happen. With patients for SIBO, you have to be, you have to have good motility, and that means full evacuations every day to make sure that the microbes doesn't stay in the small intestine and causing you more symptoms and causing recurrence after using antibiotics. And something else Brooke talked about just now is prolonged use of acid suppressing medication, right? That PPI is a specific class. Now, research on that is a bit back and forth, but I think we do see that quite often in our clinic. One of our current clients who came to us again for recurring SIBO is on the same boat. She has had reflux for a long time. I think she was on PPI for more than 10 years and developed SIBO, I think the last few years that just won't go away. And her doctor treated her with antibiotics. It, and SIBO recurred again. And I think one of our suggestions to the GI doctor is maybe switching her to a different acid reflux medication, a different class of acid reflux medication. So that's something to talk about because there are multiple different classes of acid reflux medication. If reflux is one of your symptoms, you can treat reflux with medication. It is very helpful, but you need to find one that is helpful for you, that doesn't put you at higher risk of having something else. Like, for example, having SIBO. PPI can also increase people's risk of having B12 deficiency as well. So something else to think about. But anyways, with this client, she has methanogen overgrowth. So she was significantly constipated coming into our program. And she's on a prescription medication for IBS constipation. It was working a little bit, but not working as well. We actually transitioned her out of the prescription medication onto over-the-counter laxative. And that is working a lot better for her to having full evacuation, right? And as soon as she's having full evacuation, she actually went back to her GI to get SIBO tested again. And this time she's cleared of SIBO. So I think this is the third time she got tested for SIBO. So she tested first time positive, treated it, and then tested again. She was still positive because at that time they were not working on the motility things as well to make sure she's having full evacuation every day. So that's something to really think about if you are dealing with SIBO, is having full evacuations every day, and think of all the factors that affects your gut motility, right? It's a lot. What are some of the things that we talk about? It's like fiber intake, fluid intake, sleep, stress, your routine, right? Creating a bowel regimen that helps you to have full evacuations every day. And then meal timing. And of course, exercise as well. So these are all things to consider to help you improve your gut motility. In the routine part is one thing that we say, it's really, really important to have a morning bowel routine. You can drink coffee, have a good breakfast, and go to the bathroom and have full evacuation. Maybe after 1 p.m. or 2 p.m., then you're fully evacuated. That's going to be key in stopping SIBO from coming back. And that's something, she's now having, actually we checked her stool yesterday, and looking at her stool, she's having full evacuations these days. And I'm pretty confident SIBO's not going to come back as long as we can maintain that full evacuation every day. And she learns what full evacuation means for her. Because I think for a lot of people, either with SIBO or with IBS constipation or IBS mixed bowel type, that you don't understand what full evacuation looks like. And that can look different person to person, but depending on how much food and fiber you are eating, there should be a baseline. There should be your baseline of what full evacuations look like. Okay, I'm getting off track. What? Any other things to add when it comes to risk factors for SIBO?
No, I think that's it.
Yeah. And I think too, if you have IBS, you don't have to worry about having SIBO as, oh my goodness, I have IBS, I may develop SIBO, I may have SIBO. There are some of our body's own natural protection mechanisms against SIBO. Do you want to kind of talk about that a little bit?
Sure. So our natural stomach acid is, because of the pH, that can help reduce the bacteria, also including the pancreatic and biliary secretions. These are all our natural ways of keeping our gut microbiome, part of the way we can keep our gut microbiome in balance. Our mucosal immune system, so the mucosal membrane, is what lines our GI tract. So that is got a built-in system as well. the migrating motor complex, which is what happens when our body kind of does a natural muscle, you can probably explain it better, muscle contractions to kind of get everything to move through your system. And then the ileocecal valve that is at the bottom of our small intestine closes and opens so that things don't go backwards from the colon into the small intestine.
Yeah, so some of the natural protective. I think what Brooke was saying about the contraction is what is it called? Migrating
Migrating,
motor
yeah.
complex. Yeah, so that's the contraction in our small intestine and in our large intestine to push food along. And that sometimes can be impaired by so many different things. It can be impaired by, of course, our sleep, our stress, our gut-brain interaction.
Mm-hmm.
And that's something, there are tools that we can do to help improve that. There are tools and exercise that we can do to improve our migrating motor complex. And there's also eating pattern, right? We usually recommend people who may have a disrupted migrating motor complex or SIBO recurrence, like high risk of SIBO recurrence. We usually recommend people to eat 3 meals a day, 3 solid meals a day, instead of grazing continuously through the day, right? But depending on what symptoms you have, the recommendations can be different because
Mm-hmm.
3 solid meals a day may not be doable for everybody, but it might be breakfast, lunch, an afternoon snack and dinner, but then, nothing else. But for some people, it might really just be breakfast, lunch and dinner, and they can do it and it's fine. But everybody's a little bit different, and depending on what symptoms you have. Not everybody with SIBO will automatically be like, oh, you have to space your meals out every 5 hours. Don't, talk to your provider if they make
Mm-hmm.
blanket recommendations like that. And we got a question. I just scanned through the questions. We got a question about testing. So one doctor recommends testing. The GI doctor does not recommend it. We usually don't recommend it unless, patients come to us with the test, because a lot of the times, an experienced provider would be able to ask you about your symptoms, ask you about your belching, your bloating, how long they last, to get a good assessment or get a good baseline of whether you have SIBO or not. How severe is your SIBO? Could it be other contributing factors causing you to have the bloating? Because it may not be SIBO, right? And but testing is not always required, and testing is not always accurate. So it would not be our first line of recommendation. And I think I agree with most people's GI. If treating SIBO after 1 round of antibiotics is not, doing it, or maybe after 2 rounds of antibiotics is not doing it, then it may be worthwhile to say, okay, let's, do a breath test and determine what type of SIBO you have and what combination of antibiotics you need. Because that's something, when we talk about treatment, right, that's something we want to consider, is what course of treatment we are doing, because different types of SIBO requires different combination of antibiotics, and that's in the SIBO treatment guideline from the American College of Gastroenterology. Okay, we have a question here. If you do test positive with a breath test, could there be other causes other than SIBO? Yes. Like we said earlier, breath test is not 100% accurate. There is a 47% false positive or false negative rates, which, if you think about that, it's like a flip of a coin whether you really have SIBO or not, right? 47% is pretty high false result rate. So we usually don't recommend breath test. What we would say if patients already come to us with a breath test is we ask them more about their symptoms. Like we said earlier, do you have the upper GI symptoms? Are you belching? Your bloating pattern, right? Does it correlate to having SIBO, or does it correlate to maybe having a food trigger, or maybe FODMAP related, maybe non-celiac wheat sensitivity related, or, maybe just related to your bowel pattern? That's another thing to think about as well, because for patients with IBS-C, your bloating is going to be very different from somebody who may have SIBO. And it depends, again, there are different types of SIBO, and that comes with different type of bloating pattern as well. So breath test can be helpful, but not necessary. I think I want to tread this lightly and carefully. It can be helpful, and usually we do recommend doing the Trio Smart breath test. I would say other companies, other labs have higher false results. And the Trio Smart one is better because you blow into a straw in the way they collect it, but you have to follow the instructions on the breath test very closely. Otherwise, the reason why it has very high false result rates is because the instructions is very, very different per lab, and you have to follow them very closely, and it's very strict. You have to follow a certain diet a few days leading up to the SIBO breath test, and on the day of the breath test you have to do all of these things correctly to not mess up your breath test results. Yeah, so, a lot of questions around tests, and I'm hoping maybe next year on the IBS Nutrition podcast, I can invite a SIBO experts to come on to talk about, breath tests. Is it needed? Is it not needed? Because there is, I think even in the GI world, there are two sides to it. One side is, no, you don't need to over test people, because the more you test, right, the more likely you're going to find people who may have SIBO or may not have SIBO but tested positive because of the false positive rate is so high. So, and then there's of course one side of the GI society where they just want to push test. So I think, it might be helpful to bring on an expert to the IBS Nutrition podcast to talk more about that. But as practitioners who sees patients, we don't recommend it firsthand. Do we recommend it at some point if symptom persists? If we've tried everything else and symptoms don't improve, then we sometimes do recommend it. We don't prescribe breath test. We work with the GI to get the patient's prescription. And it helps. I think a lot of our patients' doctors are very gracious when we send them notes, and they listen, and they follow the recommendation and get the testing done for our patients. One of the tests, let's talk a little bit about, some of the tests that we have our clients do. If we do suspect, there might be a inflammatory response in their GI tract, right? We know IBS does not cause inflammation, hence it shouldn't cause nutrient deficiencies. But we know SIBO does. We know celiac, non-celiac wheat sensitivity, and inflammatory bowel disease does. So one of the things we have our patients get tested is nutrient status, like ferritin, which is iron status, B12, folate, and vitamin D levels. These will give us an indication of, whether a patient is malabsorbing in their GI tract. So is it just IBS, or this is beyond IBS? And especially if we see a deficiency happen, we're like, okay, you don't just have IBS, you have something else, because IBS does not cause nutrient deficiencies. Even though it is extremely debilitating, it does not cause nutrient deficiency. Somebody asked, how was it determined that SIBO breath test can be falsely positive or falsely negative? We usually match it to the symptoms that the person is experiencing, and whether, these are signs, like the symptoms are SIBO symptoms, or symptoms are IBS symptoms, or symptoms could be something else causing it. And when it comes to GI, right, symptoms are always overlapping, but what you see is the subtle differences, like upper GI bloating, or middle GI bloating, or lower GI bloating, or with belching or gas. If it's with gas, it could be IMO, it could be intestinal methanogen overgrowth, or it could just be, you're backed up. So there are a lot of other symptoms that we watch out for when looking at the breath test to determine whether the breath test is accurate and what are the necessary steps. And usually one of the things we do first with all of our SIBO clients is make sure they have full evacuations every day, if they're not already having full evacuations. And a lot of people come in to work with us and say, I'm already pooping every day, I'm not constipated. But when they see how much stool they produce once we start using other interventions, then they realize, okay, I wasn't fully evacuating in the past, and this is what I really should be having on a consistent basis so that I don't have symptoms. So that's something else to think about too. Breath test is only one way of assessing a condition like SIBO, but the more important way of assessing SIBO is by symptoms and its correlation to whether you're fully evacuating or not and what you are eating, because what you are eating and what symptoms it causes afterwards can tell us a lot about, whether it is SIBO or IBS or, gluten intolerance or FODMAP intolerance. So these are all things that weaves together. One of the things we see a lot is actually food intolerance causing SIBO. Food intolerance causing a change in gut motility, and that gut motility puts you at higher risk of having SIBO. And oftentimes what we see in cases like this is they have overlapping symptoms with food intolerance and SIBO. But how to differentiate whether it is the food intolerance causing the symptom or SIBO causing the symptoms is to assess your symptoms when we remove the food trigger. Once you remove the food trigger, we see where your symptoms are. Like the patients we were talking about earlier who was put on PPI for a long time because she was having acid reflux, we think she hasn't done the proper test yet. But when we told her to remove 2 food triggers, her bowel movement got much better. And we think those were her food triggers. And we think the food triggers might also be contributing for her to have GERD as well, reflux as well. But we will know more after the holidays when she does the proper food challenge. But prior to removing the food triggers, she's always tested positive for SIBO. And now after removing the food trigger, she's testing negative for SIBO. So, those are other things, that can how should we say, correlates, to your breath test as well. So we don't just look at breath tests. We really look at your symptoms, what you are eating, how it correlates to your bowel movements. And anything else to add? I know this is all very confusing because there are so many moving parts.
Yeah, I think you covered it for sure.
Yeah, but one thing, we definitely recommend is stop any probiotics that you are taking. Mm-hmm. I think someone else commented earlier, the probiotics that she was taking gave her diarrhea. Again, that could be a sign of SIBO, right? And diarrhea is usually associated with the hydrogen overgrowth or the hydrogen sulfide. Yeah, so it's, there's so many moving parts and it's not always a breath test versus no breath test. Because oftentimes, even if people test negative on a breath test, it doesn't mean they are negative for SIBO. In some cases, we actually just recommend to the doctor, say, hey, I think it's best for us to try a round of antibiotics, maybe with this 1 and 2 antibiotics, depending on which type or what kind of bowel habits the patients have. If it's more constipation, we usually recommend the treatments for methanogen overgrowth and see how things go. And sometimes, another thing that we look at is the stool consistency, right? With SIBO, people tend to have stickier stools and the stool tends to be, how should we describe mucousy? Can be more mucousy. Now, mucousy does not mean you have SIBO right away. It correlates to other symptoms you're experiencing because there are other conditions where you can produce more mucousy bowel movements as well, such as if you are getting sick or if you have a bout of GI sickness or, gastroenteritis, like if you have a round of food poisoning, that would also, cause mucousy stool as well. And, that's probably one type of IBS diarrhea, right? There's so many different types of IBS diarrhea. It could be completely watery. It could be bits and pieces. It could be bits and pieces with, solid edges, but it could be bits and pieces with mucousy edges. And then it could also be like longer pieces, but very mucousy and very soft and sometimes maybe very osmotic. So even within diarrhea, there are so many different types of IBS diarrhea and so many different causes to diarrhea, which is also why we always say, say to our clients, show us your picture, let us see what your stool looks like so we can determine what your next steps are. Somebody said, I'm losing weight. I have IBS-D. Is having tea is the reason or not? And eggs are safe in IBS. If you don't have an egg allergy, eggs are very safe. Having tea may or may not be the reason. Does your tea have senna in it? I mean, what type of tea are you having? So, there are so many factors could influence why somebody have really fast motility causing diarrhea. So, but, let's go back to talking about SIBO. So treatments for SIBO, I already kind of went over that. Brooke, do you want to maybe give a more straightforward, direct overview of what treatment looks like? And then we can talk about diet.
Yeah, so if we know you have SIBO, it, the only way to really treat SIBO is with an antibiotic. Diet can help manage the symptoms, but we also make sure that there aren't things that are contributing to having SIBO ongoing, which would be the probiotics. But we actually have a client that just this fall that we thought she had SIBO, but we managed a lot of her SIBO and IBS, but we managed a lot of her symptoms with diet. But the one that threw away was the burping. And then she actually ended up testing negative for SIBO with the breath test. And we kind of recommended the breath test to see if we could get her GI to give her the antibiotic. And then she was negative. And so that, again, wasn't great. But based on her symptoms, she does have SIBO. But then again, he wanted to try something else. So then I said, if that doesn't work, then you can go back to him and say, look, your recommendation didn't work. Let's see if we can treat for SIBO and see if that solves the burping, which is a roundabout way of saying, antibiotics. But then it is making sure that your gut motility is moving at the right speed, either increasing it or slowing it down if it's diarrhea.
I know exactly who you're talking about. And this client actually came to us very, very constipated. She's done a lot of things. She's tried a lot of diets, couldn't really identify any food triggers. And we quickly identified food triggers with her and for her. And once removing those food triggers, she's having way better bowel movements. And why we suspect SIBO, there are two reasons, right? The way her bowel movement looks. It's very mucousy, it's very sticky, that gave us signs that something else is going on. It's not just IBS. And then number two is her burping. But she, even though she tested positive, we still, want to ask her GI for one round of antibiotics just to help her. I think the next step for her, what we are doing right now is following the GI's recommendations on a medication or one intervention and see how it works. If it works for her, great. If it doesn't work for her, we are going to go back and ask for the antibiotics. So, sometimes working with your physician too is to present your case very clearly and present our reasoning why we think this is, the next step. But sometimes they don't agree. And in this case, they didn't agree, but they did do all the tests that we, asked the doctor to do, and we really like the doctor and their responses. And we do agree, this could be one step we take before trialing the antibiotics, because we don't want any patients to take antibiotics unnecessarily. And that is, I think, always a concern in the back of our head, in the back of our doctors, the doctors we work with as well. So we don't want overprescription, but sometimes, having a dietitian on your team and be your advocate can really help you present your case a lot clearer. We actually have a new patient, right? You just saw her yesterday. Well, we are not taking any new clients in December because this is not a good time to start, but we are doing early enrollment. But before I tell you about her case, I want to say something. We are doing early enrollment for our January and February cohorts. So if you joined IBS Freedom Now, I think I've pinned a post on my profile so you can learn more about it. But if you join IBS Freedom Now, you can join with the 2025 pricing. Our program cost is increasing in 2026. So you can join now with the 2025 pricing and using our masterclass discount after watching our masterclass. So if at any point you comment class or group, comment group will be better, because when you comment group, I'll send you 3 links to, there are 3 links that I will DM you as automated. You will get a link to our program page, a link to our masterclass page, and a link to book a free call with me to see if the program is where it's a good fit for you or not. So we are doing early enrollment, and the early enrollment discount, the masterclass discount, is ending on December 23rd. And we actually only have 4 discounted spots left at this time. 2 people already joined before I even sent out any emails. They just saw the announcement on Instagram and they joined the program. But we did have somebody new that started with us. This is an exception because I talked to her last month and I told her, this is somebody who tested positive for SIBO, and she had a GI appointment coming up. And we talked before her GI appointments coming up, and I told her I think it's best for us to meet before your GI appointment, so we sort out what symptoms you have, how long you've had the symptoms for, and what may be the next best step for your case. I told her, this would be the best before you go in to see your GI, because you only have about, 1 hour with them if it's an initial, or half an hour, depending on where you go. And you need to convey your symptoms very clearly before they will take the action for you. And what ended up happening is she decided to see the GI first before talking to us. And then she emailed me the day of her GI appointment afterwards and said, Jessie, I went to see the GI. Unfortunately, he did not, read my SIBO breath test. He didn't care for the SIBO breath test. He said the post-infectious IBS would just go away on its own. And I don't know what to do. She spent, you go to a specialist, you spend hundreds of dollars to see a specialist for 1 session. But if you don't get anything from that appointment, it can be very disappointing, which is why I always recommend, if you have a dietitian, it doesn't have to be us. It could be another GI dietitian who is familiar with GI, but it has to be a GI trained dietitian. Go over your case with you, summarize your symptoms for you in medical terms. So when you go see your GI, you bring the list with you to share with your GI, so they take your case seriously. A lot of the times, I'm not saying they're not taking your case seriously, but you have to present your information in a way that they can understand. You have to have collected the information too, right? Like we talked about earlier, with SIBO symptoms, a lot of it is more upper GI. It's not just SIBO, but SIBO tends to be upper GI, and there's a duration for the bloating, and there are other symptoms that we watch out for, maybe acid reflux that could be related to SIBO. You want to document those symptoms very specifically for your doctor so that they can make a decision on, oh, this does sound like SIBO, okay? With your symptoms and the breath test, then we could maybe talk about a treatment course, or, put you on a diet for a short period of time. Doctors really like to do that. We don't love doing that because we know diet is not benign. It can cause people to be afraid of food, to have disordered eating behavior, or maybe even develops an eating disorder. So we really don't like that, but sometimes doctors like that. But anyways, my point is, get your symptoms organized. So when you go in to see your providers, you can communicate it clearly, and it really helps them to decide your next step. But anyways, this new client of ours, she didn't listen. She went in, wasted an hour, wasted hundreds of dollars seeing the specialist. And she came back and said, the doctor presented 2 options. One is do nothing, wait it out and see what happens. Number 2 is let's go do colonoscopy and endoscopy. And I did email back and recommend and told her, I think, if you've met your deductible, you've also passed the age of needing your first colonoscopy, it might be a good time to just get them scheduled so it is in, so you can, get these tests done, because it is routine. After the age of 45, you should get colonoscopy every 10 years if you don't have family history of colon cancer. If you have history of colon cancer, then talk to your provider, because your screening would be different. But anyways, my point is, find a GI dietitian to help you sort out your case before you see a specialist, so you're not wasting money and time and feel like you are being written off. And I felt really bad seeing her email because basically she did not like any of the options that the GI presented her with. And she said, Jessie, I'm coming to your program, but I told her, we can see you now, but you're not starting really until January, because there's limited things we can do in December. We can help you manage your symptoms. We can help you create a plan, but during the holidays, a lot of travel, we can create mitigating measures, but we can't do any of the food testing or interventions until, your life is more stable. So, Yep. So I just want to bring that up. How did I even get there? Sorry. But, I'm hoping to help you not waste time and money when you go see a specialist. Really learn to document your symptoms. We have a patient, oops, I hope my phone doesn't fall off. I think a lot of you know this already. We have a patient IBS toolkit that you can grab for free that really teaches you on different types of IBS, risk factors for IBS, a care team, what it looks like, and also a symptom tracker. We get to it. It also have some FODMAP information, but it's not for everybody. But the symptom tracker to really learn more about your body. You can comment symptom at any of my posts. You can do it here as well. And then I'll send you a DM to ask you for your name and email address, and we'll email it to you. This is a very big document. We can't just send it out here. When you get the email, you will get a link to download it for free. It's completely free. Understanding your body is really key for you to get help, because then you can present your symptoms clearly with the provider that is helping you. Otherwise, a lot of the times we ask a patient, where's your bloating at? The patient's like, bloating at? I'm just bloated. I don't know. When does your bloating happen? I don't know. It happens multiple times a day or multiple times a week. I don't know when it happens. Does it correlate to what you're eating? Maybe. Does it correlate to your bowel movement? Maybe. Like, if you tell us these kind of answers, then we really can't help you. It's the same as when you go into a specialist. If they're asking you all these questions and you can't give them solid answers, there's not a whole lot they can do besides say, well, let's order some tests. Let's rule out celiac disease, inflammatory bowel disease. Let's rule out maybe H. pylori or maybe whatever else, depending on what symptoms you have, to see what may be going on, because they don't fully get the picture. So understand your body first. Okay, let's go back to talk about SIBO and diet. What are some diets for SIBO?
So any diet won't eradicate SIBO. The diet that we like best would be trialing, we like the low FODMAP diet. There's also the low fermentation diet. Those two have some research behind them for helping with SIBO. Low FODMAP, FODMAPs are fermentable carbohydrates. And so the microbes really do like those fermentable carbohydrates as their preferred food source. So when you eat a high FODMAP food, the little SIBO guys get kind of excited, and then they digest those foods and produce gas. And that's where the bloating and gas can come from with the FODMAP. So low FODMAP can help keep your gas and bloating at a lower level than eating high FODMAP foods.
You're basically removing some gut irritants, but you don't want to do it long term. Like we keep saying when we are meeting and talking about this, is the low FODMAP diet is not long term. And in the long run, when you remove all these fibers that are prebiotics for your gut microbes, it can shrink the microbes that can help you break down the FODMAPs. And hence, you can become more sensitive to these FODMAPs when you eat them, because you don't have the ability to break them down. I mean, our body don't, but the microbes can. But if you starve the microbes, then they may not be able to help you as much, and you become more sensitive to it. Now, don't fret. I know this sounds really scary, because a lot of the times patients come to us having cut out FODMAPs for years. And it's okay, because we can always rebuild your gut microbiome. And the only way to rebuild is to eat these foods again. right, in the quantities and amounts that you can tolerate so that your gut microbe starts thriving again. But being low FODMAP can temporarily help manage symptoms. And oftentimes with an experienced dietitian, this is also the time we go dig in to see, what may be causing your SIBO. What are some of the risk factors? Do you have something else causing you to have a motility change that puts you at higher risk of having SIBO and SIBO recurrence? Somebody else here said, I failed antibiotic twice. This is something we hear again and again, because oftentimes, just prescribing antibiotics is not enough to treat. It can be enough to treat SIBO, but if you don't look into what is causing the SIBO and stop that for good, SIBO will more likely come back. Okay, there's another question, and I want to actually share a client case story too regarding to recurring SIBO. This is somebody who is a healthcare provider who works in surgery, and she came to us for recurring SIBO. She was on antibiotics 3 times. The first time it works great. It stopped her SIBO. She has the SIBO diarrhea type. The first time it stopped her diarrhea really quickly. The second time it still stopped her diarrhea, but her diarrhea came back faster. And the third time of using the antibiotics, it didn't work at all. And that's when she freaked out, and her doctor said, well, why don't you try the low FODMAP diet? And that's when she came and joined our program. This is, she works in surgery. Her name is actually Cynthia. She's the loveliest lady, and she was very smart. And when we were working together, she's already cut out a lot of food because she was told to try the low FODMAP diet. And this is a warning for those of you listening. Low FODMAP diet is not for everybody, and you really shouldn't do it by yourself, because when you cut out more and more food, you become more and more afraid of them because you don't know how to reintroduce it. And I want to tell you this. She didn't have any food trigger, and here is what happens. Because she works in surgery, she has a very tight schedule. She gets up at 4 a.m. She has to get to the hospital before around 6 or 7 to get ready. So she actually was very constipated. That caused her to have slower gut motility, and that slower gut motility put her at risk of having SIBO. And the SIBO she got, of course, was causing her to have diarrhea. So the doctor was just treating the SIBO and treating the diarrhea. But when the diarrhea stops, she reverts back to having constipation, and the constipation again gives her SIBO. And that's also why the antibiotics didn't work the third time, because they were not treating the root cause that was happening, and the root cause was constipation. And when we started working together, I think that was the first thing we did. As she was getting treated for SIBO, and then she was on the low FODMAP diet, she's already put herself on it. We saw what was happening when she was on the antibiotics. She actually wasn't really pooping much, especially given her very busy schedule. She's just had a lot of backed up. But once we resolved the motility issue by just increasing fluids, increasing fiber, and also creating a bowel routine that works for her in the morning, prior to going into surgery, when she had full evacuations every day, her SIBO stopped for good. And she didn't do a FODMAP challenge at all, because she actually just started tolerating all FODMAPs, and she started eating all FODMAPs throughout the 4 months that we were working together. And at our last session, she told me, Jessie, I had street tacos with raw onions on top. I was a little bit worried, but when I ate it, I didn't have any symptoms at all. And we all know onions are a big FODMAP group, right? It's not really allowed on the low FODMAP diets. I mean, yeah, it's not really allowed on the low FODMAP diet or even the low fermentation diet. But at the end, she was able to eat that and not have symptoms. And because she is also a healthcare provider herself, she knows, like, Jessie, I now know, if I'm not having full evacuations, I'm going to work on increasing my fiber. I'm going to work on increasing my fluids. Then I'm going to have full evacuations again. And that's how, we stopped her SIBO for good. That is one case where, she doesn't have a food intolerance. But there are also a lot of cases we see people do have food intolerance, causing the motility change, causing them to be susceptible for SIBO recurrence. And in those cases, you have to identify what food that is causing the change and how much of it you can eat. Some of the food, you cannot eat it at all. Some of the food, you can eat small amounts and you will be fine. So, it really depends again on what is causing your SIBO to figure out a treatment plan and then maintain that plan consistently so that you can stop the recurrence for good. We have a question here that I think is really, good to answer. How often is SIBO diagnosed in your practice? Is it pretty common or does it tend to be isolated cases? So we are dietitians. We don't diagnose. We usually have patients come to our clinic with a SIBO diagnosis already, and they are frustrated with the treatment options they have, and they keep getting recurring SIBO. So we work with patients who already have SIBO. Now, do we have cases where we suspect SIBO, like the case we talked about earlier, that we actually recommended the GI to get a SIBO breath test for our clients? We do get some of those cases where we work with the practitioner, with the doctor, to get to the correct diagnosis for our patients, for our clients. But not everybody has SIBO. I would say, since we don't diagnose, I can't give you a percentage of how many we diagnose because we don't, but we do see it pretty often. But because SIBO is a more difficult condition to treat, a lot more complex than just IBS. So we see it quite often because our program is pretty high touch, right? We are meeting with a patient every week to get them to feeling better quickly. So we do see a lot of complex cases. I would say maybe half or maybe one third to half of our patients come to us with SIBO diagnosis. And maybe like 1 in 10 patients, we suspect SIBO and work with their doctor to get them tested. Does that sound accurate?
Mm-hmm. Mm-hmm.
Yeah.
Yep.
So, most people come to us who already have tested for SIBO or have a SIBO diagnosis already a lot of the times. We have a question about what is the difference between SIBO and IBS. We have a post about this that is on my profile, but we also talked about it earlier during the IG Live. I will share the recording when we are done. And it's not that common. I think some of the research in the past that said 70% of IBS patients have SIBO. That's not true. Mm. I think newer research have suggested that the number is a lot lower. Maybe 20-30% of IBS patients may also have SIBO. But again, SIBO is a diagnosis, right? And if you don't know what's causing the SIBO, you need to know that for it to stop coming back. Okay. Oh, and somebody said, yes, and RD makes a wonderful advocate. Thank you. Yes. Mm-hmm. Advocating for you and for your symptoms and get the right treatment is really important. And the person also said, my RFID got a little triggered during some of the FODMAP challenges, and that turned out to be safe after all. Yes. Oh my God. I love that. That's what we always want to hear. Actually, let's talk a little bit about that. A lot of people who come to us have a lot of food fear already. And one of the things that we really work on with our clients is reintroducing the food, right? It's because when you reintroduce it, you know whether you tolerate it or not. And whether you, how much of it you tolerate, then you can keep eating the safe amount instead of being really afraid of it. That is always the goal of working with us. Oh my goodness, I see AGA joined us, American Gastroenterology Association. Hi. Yeah, we love seeing you here, and yes. Let's see. Do we have anything we did not cover? Oh, what are helpful measures? Let's talk about that because we just finished talking about fiber. So maybe what are things that can be helpful for dealing with SIBO?
Yeah, so fiber can be helpful. We usually recommend psyllium or PHGG. You want a fiber that has a good solubility, viscosity, and very low fermentability because we don't want a fiber that's going to increase any gas or bloating by fermenting. But the evidence really isn't super strong that this is helpful, but it's still a good thing to try, relatively benign. You can start at a really small amount and kind of increase as tolerated. And what else? We don't like probiotics.
No probiotics cause SIBO. Be very careful if
Yeah.
you have,
Yes.
rapid change of gut symptoms. Once you start the probiotics, know that it's probably that.
Hmm. Yeah.
Yeah, so that's pretty much it. Let us know if you guys have any questions. I think we've also been answering questions along the way. And for those of you, who might have been dealing with SIBO for a long time, you really want help, we have opened early enrollment for our small group program for January and February. So for those of you, if you join now, you get the 2025 pricing plus our masterclass discount. That discount is going away very soon, within the next 2 weeks, and it is $500 off. So it's not nothing. It's a big discount. So this would be the lowest cost to join our program and get our help in 2026. And when you join now, you have access to our course. You can start working through the course and try out the strategies we have and document your symptoms as you are trialing different strategies. And then come January, when you have your first one-on-one appointment, it would be really helpful, for us to ask you what your symptoms have, your medical history, and what strategies you've tried and how you're responding to it. Then that way, it will help us create a better treatment plan for you when you start working with us and start maybe doing different interventions or elimination and challenging foods. If we don't think elimination is necessary, we usually don't recommend elimination. A lot of people come to us already eliminated a lot of food, and what we really focus on is challenging the food as soon as symptom is stabilized. Okay, and we've got somebody say relaxation techniques also helps too. Yes, absolutely. I love settling into my heating pad after meals. We have actually a lot of relaxation techniques incorporated in our course, in our program. And what we usually like to do, because changing habits is very hard, we have our clients focus on one lifestyle modification a week to build the habits, to reinforce the habit. And we always start with deep diaphragmatic breathing because it stimulates your vagus nerve and it calms the gut-brain axis to help improve motility, improve digestion, and help you feel better. Somebody asked, what fiber do you recommend? You want to talk about that?
Yeah. So
Yeah.
psyllium or PHGG, we don't have I don't think we're supposed to recommend a particular brand, but the brand doesn't really matter. As long as we do want things to be safe and tested for additives and things. But psyllium or PHGG, you can get them flavored or unflavored, at least for the psyllium. It's kind of your preference.
Yes, so there are a lot of name brands out there in terms of psyllium. You can try them to see if you tolerate it. Psyllium is usually the number one that we would recommend because it's more cost effective and it has 3 different fiber characteristics that can be helpful for IBS and potentially SIBO. One is, Brooke mentioned this earlier, the solubility, right? Does it dissolve in water? And once it dissolves in water, what is viscosity? And what that means is whether it is gel forming or not. Because soluble and gel forming fiber can help soften stool for those people with chronic constipation to help the stool come out easier. And for people with chronic diarrhea, it can actually bulk up stool and improve your stool form and stool consistency, which is also why, psyllium is usually the number 1 recommendation for GI disorders and for IBS. Now, number 3 fiber property that we really need to talk about is fermentability. So for patients with IBS and SIBO, we do want to find a fiber that is not fermentable, and psyllium checks all 3 boxes. It's soluble, it's viscous, and it's not fermentable. So it's not going to cause more gas and bloating to help you when it's improving your gut motility, or it is help slow down your diarrhea to bulk up the stool a little bit more. So that's what we recommend. And when you do trial psyllium, go very slow, right? Sometimes, if Depending on how sensitive your gut is and how severe your GI disorder is, sometimes we tell people to follow the bottle, start with 1 serving. Sometimes we tell our patients that your gut is so sensitive, I would not, start there. Let's start with 1 teaspoon and see how you do. If you do well, then increase. Be very careful when you're increasing fiber as well. You have to increase fluids. If you don't increase fluids, it can make things worse. You can
Cement.
become, it can cement in your gut and make your constipation worse. Now, if it's diarrhea, it can still irritate your gut a bit more if you are not increasing fluids. And if you already have diarrhea to begin with, you really want to stay hydrated. Maybe even adding some electrolyte, depending on what type of diarrhea you have. We see a very wide range of diarrhea. Some cases, people pooping tiny little bits throughout the day. Some cases, they just have watery diarrhea for 1 to 2 hours a day. Depending on the severity of your diarrhea, treatments, again, is going to be different for everybody. What about for gastroparesis? I have a hard time with celium. With gastroparesis, you may not want to be trialing fiber. It's not recommended. I don't think so. Yeah. So, again, based on what symptom you have, what other diagnosis you have, the recommendation is very different. Now, if you just have IBS and SIBO, you can try a little bit of fiber, start very small, drink a lot of fluids with it to help it move through. I think this might be a dietitian. FODMAP often works well for diarrhea, but what do you think about using FODMAP for constipation? We actually had a video recently in November that talked all about constipation. So it depends on what's causing the constipation. The low FODMAP diet is not always the best, but you also need to use other interventions or other modalities to resolve the constipation first before reintroducing FODMAPs. Otherwise, FODMAPs goes into your colon, they get stuck, they get fermented, they cause pain, they cause gas. That's the same for SIBO, really. Okay, so I think this really wraps up our conversation on SIBO. For those of you who are just joining now, I will post this video very shortly onto our my Instagram page, so you can watch the replay. And for those of you who want to work with us, a quick reminder, we are enrolling our first group of IBS Freedom Group Program. Either you can choose to start when you join now, you can choose to start in either January or February to kick off your program. But you have access to the course right away, so you can use the holiday to work through parts of the course prior to starting your program with us. And what I mean by starting your program is start your meeting with us in the group coaching. Yes, and if you join now, you do get to join at the 2025 pricing with the masterclass discount, and that is $500 off your program price, which is a lot. So you can comment group to get the link to our group program to learn more, and get the link to our free masterclass, and also get the link to book a call with me to see if this is the right program for you. And we would love to help you overcome SIBO if that's what you're dealing with. But we really work with all GI conditions. I think when you work with IBS, we are really working with everything. We work with inflammatory bowel disease, especially microscopic colitis. We also work with celiac disease. We also work with, what do we see? We also work with bile acid malabsorption, exocrine pancreatic insufficiency, because sometimes with diarrhea, it may not be IBS diarrhea. It might be something else causing the diarrhea. So, when you work with IBS, you see everything. So, all right, everybody. Thank you so much for joining us. We will do another live next week. And next week, we're going to talk about, getting through the holidays with IBS. It is the holiday season. It is travel season. And we know when routine change, habit change, food change, people tend to get more symptoms. So we'll cover a lot about that and maybe give you some tools to help you, hopefully prevent symptoms or find relief during the holiday season. Thank you, everybody.
Bye.
Bye.